Hi, class. Today we're going to continue our discussion of the treatment management of pediatric swallowing and feeding disorders. This is the second half of a two-part lecture on this topic. Now, we're going to focus in this lecture on older babies and children and end with a brief discussion of adolescents and difficulties they might have with swallowing that are unique to their age group. So if we look at the themes that I can see with regard to intervention for older babies and children, just as with neonates, there seem to be a number of important topics that run across techniques or plans. Let's take a look at those. The first is this continued importance of meeting the nutritional needs of the child. It's critical in neonates that they ingest a specific number of calories that has been determined to be necessary for them to thrive. That continues to be important in older infants, so 6 months up through toddlerhood, and also in children. At this point, however, slightly later in their development, a few other things have had a chance to develop or mature. Some of the urgent problems of a post-birth infant may have been resolved. In these slightly older children, we are moving on towards the developing skills that they're going to need to ingest solids. And if they are ingesting solids, they're able to sit and take solids and liquids as PO, then they're going to be working on expanding their inventory of the foods that they can tolerate. And they're also going to be developing specific eating skills that you need to deal with solids, such as mastication. Luckily, at this point, most of these children have their dentition, so it's a question of getting the skills they need to prepare solid material. In these older children, we will also be using often adaptive feeding equipment as needed, similar to the discussion that we had in assessment. These might include special chairs, special cups, special weighted implements, etc. These older children may already know self-calming procedures or self-calming methods that they can use to quiet and ready their system to take in food. They may have also learned to modulate or make more reasonable their sensory response. And if they haven't, if they still are distracted by sounds and tastes and light, that's really a target for improvement in this age group. Finally, because of the lengthening of the larynx and the developing of the laryngopharynx, airway protection becomes very important, and you start to enlist the self-help of older children in protecting the airway as they swallow. Now, in this group, one topic that I wanted to address is the topic of speech and language acquisition, which is taking place at about the same time for our patients with swallowing and feeding disorders. And you may be working on both sets of skills at the same time in your treatment program. So a few of the things that I wanted to cover sort of center around the idea that you have one mechanism that you use for speaking and swallowing, and you might be treating the mechanism hoping for a dual outcome, but you have to be clear in terms of your theoretical motivation for adopting a particular approach. The best example of that is oral motor exercises. Now, as you know, there has been a long history in our field of using oral motor exercises to improve articulation skill. We now know that there is no carryover, no transfer of improvement in a static or even dynamic oral motor exercise into an articulatory benefit. However, there's something to be said for working with a child on strengthening for swallowing purposes and having sort of increased awareness of their control over a particular structure as that structure then relates to articulation. And although there may be no direct transfer of strength in the tongue to better articulation, there may be some benefit of having this common vocabulary that a child knows when you're talking about tongue up. They know kind of where that tongue is supposed to go. In terms of the sensory awareness, again, we have a long history of treating children who have sensory impairments, either hypersensitivity or hyposensitivity, particularly in the oral mechanism. And the general idea is that children who have hypersensitivity in particular are going to be resistant or unable to benefit from placement cues in articulation. And that is still the commonly accepted wisdom today. However, knowing something about what the sensation means in terms of where a structure might be, again, might have some dual benefit in terms of eating and talking. The most important aspect that is shared by eating and talking, I think, is the fact that both of these are social acts. So although we're consumed, sorry, I guess that was a pun, by the idea of feeding children in a way such that they get enough nutrition and their airway is protected, eating and food is an indelibly social act, as is communication. We will talk very briefly about treating children in groups, but groups for feeding therapy for children, for toddlers, can have both speech and language benefits as well as the sort of oral motor awareness and perhaps increased skills in oral intake. Finally, I just wanted to throw out there that language stimulation activities can also be a big part of feeding therapy, just like articulation work and feeding therapy can coexist. So let's say that you are emphasizing food preparation activities for the picky eater, for a child who has a very restricted inventory of foods. You can do language and articulation stim, and at the same time then that you're using that activity to be generating a food that you can use in a feeding group. Now, if we look at slightly older children, let's say school-age children, they encounter a number of fairly specific concerns, and the biggest one of these is about facilitating intake of food and facilitating safety, airway safety, in an educational environment. So those of you who work in a school know how noisy, distracting, full of unexpected developments a school environment can be, particularly around lunchtime. And it is a matter of concern as to how you're going to help maintain the safety of a child who has dysphagia or has some kind of eating impairment once they get around to other children who are also eating. I think there are a couple of factors that are related to that. We're going to skip down a little bit now. One is the length of time that it might take for a child who has poor motor control, who's hypotonic, etc. The length of time needed for a meal for that child might be rather long and may not fit into the school day of you have 20 minutes for lunch. Likewise, there could be social consequences for kids who have eating problems. So the kid who's a messy or slow eater or a picky eater is going to have to contend with the reactions of their peers. And that can make it difficult for them to accomplish feeding in a safe and timely manner. And back up to the use of strategies here. If children have begun using some strategies for airway protection, let's say a chin tuck or an effortful swallow, how reliable is it going to be for them to use that strategy in that busy, noisy school environment? A few other things to think about for school-age children, and again, older, slightly older. So we're moving towards teens and adolescents. That will be our last slide. It's very tempting when you get a 12, 14-year-old to start to think about them just as a smaller adult. And this problem is complicated by the fact that the assessment techniques that we use with children who are that old are the same as we use with adults. The problem is that despite their ability to follow directions, participate in a task, etc., these are still children. And they may have cognitive, I'm not going to say impairments, but limitations that relate to their age that are developmental. So they do not have adult judgment, the adult ability to ignore distractors. They may happen to feel quite uncooperative on a day when you want to do assessment. So it's not just the case that you have a small adult. You have an older child who still has some unique problems and who still has anatomy and physiology that's developing. So they do not yet have the adult instrument. Again, it's tempting looking at the outside to think, okay, this is a small adult. But in reality, while the relationship between structures has gotten more adult-like, size and ultimate motor control has not yet attained adult status. For school-age children who have a pretty severe medical diagnosis or etiology, so that I'm thinking now about TBI survivors or cases who have suffered anoxia. They may have widespread brain damage, and dysphagia becomes just one small part of this constellation of problems that they have. And it is not always the case that we can work on everything at the same time with the same efficacy. So these kids will have multiple health problems. They will also have communication problems. And so it becomes a matter of balancing priorities, of really thinking about, is my target at this moment oral feeding, or is my target at this moment increased awareness, appropriate sensory response, etc. And finally, behavioral issues can really complicate things, as those of you who have teenagers or at least preteens undoubtedly know. At this age, cooperation is iffy, and under the best of circumstances, and kids who have swallowing problems are not going to be any different. So you may have all the best intentions in the world, as do the parents, but the week that you want to work on a specific skill to improve a swallow, the child may not be in the same place as you are, and you kind of have to take that into account when you're planning your sessions and also you're looking at your progress. Finally, to adolescents, boy, the temptation really is now to consider adolescents, so kids in their teens, to just be little adults. That's still an inappropriate conclusion for us to reach for a number of reasons. One is, at this point, kids who have dysphagia or swallowing, feeding, tonicity problems may have a long-standing problem with eating, and they may have had enough time to build up really a long negative history about mealtime and about consuming food. So because of this, it is often difficult to work with them towards any kind of oral improvement because their history has been so negative. The flip side of this would be that adolescents can have a new problem related to neurological damage. This group, adolescents, is extremely prone to traumatic brain injury, and that's a leading cause of disability in teenagers. So you have long-standing problems and brand new problems in this group who is approaching an adulthood but is not quite there. And although they are older, they still have what I'm calling cognitive limitations. I suppose I should call them developmental cognitive limitations. So they may or may not have good judgment, ignore distractions, and be cooperative. Now, there are two aspects of eating, swallowing that seem to be pretty tied to the teenage years. You can find references to these two problems that I will discuss next throughout the internet. The first one is the group of teens who have a single choking episode. Or a few choking episodes. They choke on a chicken bone, or they have a virus and they have a lot of mucus, and so they choke while they're eating. They can, in fact, develop what is called a fear of choking or a fear of eating. There is a great little, very brief article on the Swallowing Disorder Foundation page. So if you go to the Swallowing Disorder Foundation on the internet and after the / here, type in adolescent, you'll get the brief discussion of this particular eating problem. The other issue is that seems to be fairly closely tied to being a teenager, although not always, is the disorder of achalasia. Now, achalasia is a failure of the digestive muscles to relax. There are cases of achalasia in early childhood and also in adults, so it's not medically limited to teenagers, but it does seem to proliferate in teenagers. I imagine there's a number of different kinds of reasons for this. One would be that this group is, by their very age, a group that is full of anxiety and stress about their social standing, about relationships, about their place in life, about school, you name it. And because of this, then, they seem to be fairly prone to somewhat specialized disorders that relate to inability to tolerate food or a fear of taking in food. Facebook has an achalasia support group. So if you go to Facebook and you type in achalasia support group, you'll be able to see that it's an open group, But it does seem to me, reading through it, at least postings in the past, those participants, many of them seem quite young. So it does seem to attract teenagers who are afraid that now this is going to be their new life, that they're not going to be able to eat because their smooth muscle cannot relax, and they end up with a number of different digestive problems because of that. We'll end this discussion of our teenagers just with a precaution, and that is, again, for some of the same reasons that we find unique eating problems and swallowing problems in this group. So that would be anxiety and stress, sort of coupled with, cognitive differences as compared to adults. That this group is also prone to eating disorders, as that term is used in the psychiatric literature. So children and teens who have bulimia and anorexia may, in fact, develop or also have dysphagia or swallowing problems, particularly cases with bulimia who have had a history of vomiting and purging, and who may have reflux-like damage to the esophageal and pharyngeal structures. Kids who have eating disorders are not our bailiwick. As I've said earlier, it's very, very important to understand what is our scope of practice and what is not. And this does actually relate to issues about finding a team with whom you can assess and treat children who have eating disorders, because then you get the benefit of multiple professional viewpoints, and it's very helpful in those psychiatric eating disorder cases to have other resources to offer those kids.